So yeah, it's my pleasure to introduce you Dr. Taban. He is a specialist pulmonologist and physician practicing at Mediclinic Midstream. He obtained his MBCHV from Medunsa, completed his MMed in internal medicine at the University of Victoria, and subsequently earned his certificate in pulmonology through the Colleges of Medicine in South Africa. Beyond his clinical work, Dr. Taban is widely admired for his remarkable journey from refugee to internationally recognized physician, author, and advocate for equitable healthcare. He has been at the forefront of respiratory medicine and critical care, and his dedication to excellence and compassionate patient care has made him one of South Africa's most respected pulmonologists. Thank you so much for coming to present to us.
Thank you, Dr. Gardinio. Looks like my bio is changing every time. Thank you for that.
We have to keep it interesting.
Today, I think our discussion is going to be focused on the really topic, the conditions that we see on the daily basis, either in your practice, either your family, either your neighbor, what we call connective tissue disease. So connective tissue disease, ILDs, or interstitial lung disease, a heterogeneous group of fibrotics and inflammatory lung disease. I like fibrotic and inflammatory because they help you really to understand how to treat and how to actually approach them. So the scope of presentations really would focus on the systemic sclerosis ILDs, RA-ILDs, and also idiopathic inflammatory myopathy, inflammatory ILDs, and other such as connective tissue disease, such as Sjogren, mixed connective tissue disease, and SLE. I'm not a rheumatologist, I'm a pulmonologist, as you heard on the bio, and also means I'm just giving a perspective of pulmonology part of it. Now, why connective tissue disease matters? Because it's a major cause of non-idiopathic fibrotic lung disease, require multidisciplinary diagnosis and high morbidity and mortality, precision classifications, improve outcomes. Now, if you look at the 2025 ATS ERS ILD framework, where they divide ILD into clinical pathway, which you got your connective tissue ILDs. Those are patients really got an underlying connective disease confirmed by rheumatologists, such as systemic sclerosis, RA, or myositis. And the second group are what we call IPAP, idiopathic pulmonary fibrosis with autoimmune features. So this patient really got confirmed lung disease, but they have some features of connective tissue disease that either can evolve into complete full-blown connective tissue disease or never at all. And of course, the last group are the patients with ILD that develop progressive pulmonary fibrosis, ILDs. And then morphological phenotypes, of course, those will be your NSIB morphologies, UIP pattern, organizing pneumonia, and or LIP. Now, the prevalence of the connective tissue disease, ILD across connective tissue disease, let's look at the global evidence. Let's start with the international evidence. So international evidence, of course, is you look at that, if you look at the international evidence, ILD is present across all the connective tissue disease. The highest full prevalence in systemic sclerosis and mixed connective tissue disease, 56% besides 47%. And of course, there's a wide variation reflecting heterogeneous and methodological, of course, and ILD definitions. Now, when you look at South African data, systemic sclerosis cohort, there are a number to treat 98, there are about 40% prevalence of ILD in horizontal CT scans, and about 39% had moderate to severe lung disease. So highest burden, of course, in South Africa is in systemic sclerosis. So Cape Town CT ILD cohorts, number to treat 124, and so RA-ILD was predominant with 29.8%, followed by systemic sclerosis, 25.8%. However, if you look at the key demographic or systemic factor in South Africa, of course, is that there was a strongest female predominance, about 89%. There's a peak presentations, middle age about 40 to 60 years old, and a significant burden among Black Africans and mixed ancestral populations. However, the problem in South Africa, we think that is likely underdiagnosed due to limited horizontal CT access in South Africa, and mostly in our rural areas. There's also obviously there's a delay rheumatological referral, because again, if you look at the government sectors, only the rheumatologists are finding big academic centers. In private sectors now, I think the number of rheumatologists are increasing. And of course, again, you should not forget about the presence or burden of pulmonary tuberculosis. That, of course, the radiological evidence sometimes can make people can misdiagnose as a TB instead of actual interstitial lung disease. Now, what's the take-home message? Of course, that connective tissue disease, ILD, is prevalent across connective tissue disease, with the highest burden in systemic sclerosis and mixed connective tissue disease. South Africa, prevalence and significant underdiagnosed drives, with support for need for proactive screening strategies across all connective tissue disease. Now, the screening strategies across about the screening strategies. Why do we always have to diagnose ILD at the later stage? The problem that because ILD can present from silent disease to overt symptoms. So the early, of course, the screening earlier and acting early is quite very important. So ILD can present as asymptomatics with no dyspnea, cough, and this is really subclinical disease and may present with actual normal lung function. And those really require high index of suspicions. And if we can catch the patient at symptomatic stage, probably is one of the best, and that can prevent fibrosis. The second group, of course, that some patients, of course, once they miss a symptomatic stage, they develop they start the beginning of the symptoms, which is, of course, a symptom of occasional or external dyspnea, intermittent cough, subtle functional decline. So this is really quite a window of early detection interventions. And a symptomatic phase, which is predominant number of patients within a private practice and across all spectrums. Most of these patients that come late, they're already having dyspnea on minimal exhaustion or at rest, persistent cough, and functional impairment. So this is a high risk of progression and irreversible fibrosis. And that's why we don't want to find them. We want to find them quite much more earlier on. Now, this challenge of silent connective disease need for screening. In the past, we were told that actually you must have to wait for symptoms. You must look at the symptom for you to actually cause the screening. However, if you have to wait once the patient got symptoms, we have missed the opportunity actually to pick up the ILD, and most of the patient will have fibrosis. Now, why symptom-based screening fails? Because if you look at the ERS, EULA 2020 and 2020 recommend emphasize symptom-based screening alone is inadequate for detecting early CTD ILD. So we shouldn't be using symptom, because most of the patients already, when they have symptoms, they already have significant high-resolution CT scan fibrosis. They're always progressive interstitial abnormalities, and some of these patients actually have normal baseline spirometry and preserve FBC-DLCO ratio. So silent ILD may remain asymptomatic despite structural advanced disease. And the most important one, of course, rheumatoid ILD. Most of patients with rheumatoid arthritis, up to 30 to 60% of patients with RA may demonstrate subclinical ILD change on horizon CT scan before overt respiratory symptoms. What should we consider? Who should be considered for screening? Of course, patients with high risk connective tissue subtypes such as systemic sclerosis, dermatomyositis, rheumatoid arthritis, and primary subgrade syndromes. The presence of serological autoantibodies associated with ILDs, those would be anti-SLC70, that one's scleroderma, anti-RO or SSA in Sjogren, anti-JO1 in the antisentinel syndromes, and one of the potent antibodies, of course, is MDA5, which is where most of those patients who really have no window of opportunity, because those patients present really very, very sick young patients. Older age, male sex, smoking history, and abnormal chest imaging such as crack holes or interstitial change on chest X-ray or press CT suggest ILD, and the decline lung function such as FBC or DLCO even within the normal range. So the take-home message on this slide is because CTD ILD can be silent, proactive screening with the pulmonary function test and horizon CT in high-risk patients enable early diagnosis, closer monitoring, and timely intervention before irreversible lung damage occur. So now, evidence-based indication for horizon CT. So horizon CT now become the modality of choice for screening these patients. In the past, we could have used the chest X-ray, but now the chest X-ray has no role at all. We should be focusing on horizon CT scan. Now, indication for horizontal CT scan in CT ILD, of course, is when you suspect ILD in chronic tissue disease, unexplained dyspnea, cough, or abnormal pulmonary function test to detect early ILD even when chest radiography is normal. Baseline assessment define ILD patterns across UIP, NSIP, organized pneumonia, or LIP, etc. Assess extent and severity of disease. Prognostications, of course, of prognosis, to really to monitor the extent of fibrosis on the horizon CT, predict FVC decline and mortality. Detection of high-risk features such as UIP, pattern, honeycombing, subpleural sparing, because that has really quite prognostic values. Monitoring disease progressions and exclusion alternate diagnosis. So the screening, of course, the new screening guidelines say that the patient who should be screening, any patient that present with you on your practice for the first time with either mixed chronic disease or scleroderma or systemic sclerosis, those patients need a start horizon CT scan. Now, evidence supporting the role of horizon CT in ILD, of course, which is, of course, the high diagnostic accuracy, because if you do horizon CT, of course, you got high diagnostic accuracy. Horizon CT detect ILD in 20-30% of chronic tissue disease patients with normal chest radiography and abnormal lung function tests. And pattern determining prognosis, obviously. Obvious one is a percent horizon CT scan. If you will be able to know the pattern. UIP pattern horizon CT is associated with worse survival compared to with NSIP pattern. Extent, of course, of fibrosis also predict decline. And horizon CT also detects progression earlier. And guideline recommended, of course, that horizon CT as an essential for diagnosis, classification, and monitoring of connective tissue disease. AI is one of the hottest topics in the I think for the last 3 years. And AI, whether you like it or not, is here to stay. So computer-aided diagnosis is now used to detect vessels-related structures, a powerful predictor of FVC decline that often eludes human eye in early disease stages. And I'm very aware that most centers in Europe already they are training the AI to actually analyze our CT scan. Sooner or later, we don't need a radiologist. So the AI, of course, predict faster FVC decline independently of reticulations, detects subclinical vessel-related structure invisible to the human eye, and enable early risk stratifications and interventions. Now, in 2026, the hierarchy has changed. To diagnose an interstitial lung disease, the hierarchy, the first line is horizontal CT scan. AI tools improve detection of vessel-related structure and subtle ILD patterns supporting early and market. Once you have horizontal CT, the next is a multidisciplinary discussion. Means you cannot diagnose ILD as an individual. You need to have multidisciplinary discussion. And the third, of course, in doubt, you can do transbronchial cryobiopsy, which has become a gold standard. Now, what's the pathophysiology of the chronic tissue disease? One, it's inflammatory process. If you look at our definition, where you have immune activation and release of pro-inflammatory cytokine, chemokine lead to recruitment and activation of inflammatory cells in the lung. The recruitment, of course, that will be a monocytes, and then they differentiate into alveolar types, M1 or M2. M1, which is a pro-inflammatory cytokines, they're induced by interferon gamma, LPS, TNF-alpha, and GMC CSF. And those really give you what we call NSIP pattern. And then if the macrophage differentiate into M2, that give you what we call fibrotic process. And this normally M2 results when there's persistent injury and disintegrated repair, promoting fibroblast activation and extracellular matrix deposition, leading to fibrosis. And when you have this excessive extracellular matrix deposition, and those patients really develop what we call UIP pattern. And it's very important because the treatment is different. And then, of course, lastly, the alveolar filling process. In addition to fibrosis, alveolar space may be filled with inflammatory cells, proteinous materials, or edema. And this will lead to what we call overnighting pneumonia. And most of those patients are steroid responsive. Now, bronchoalveolar lavage in the connective tissue disease, bronchoalveolar lavage is something that's been taught at pulmonology through bronchoscopy. This question, the take-home message that bronchoalveolar lavage is used to exclude infection and characterize the inflammatory phenotype, but it's not diagnosed a particular kind of ILD. Okay, the clinical roles is not diagnostics, exclude infections, and also when you have acute worsening, it helps to disengage an infection or just acute progression. And also what it does, it exclude drug-induced ILD, because some of the drugs that we use to treat ILD can also cause interstitial lung disease. Cellular profiles, of course, normally when you do bronchial lavage, we send them for immunotyping, and you can have macrophage, normally 40 to 80%, lymphocyte, and neutrophils and eosinophil. Interpretation, of course, is normally lymphocytic are inflammatory, and then neutrophilic are fibrotic, eosinophilic means drug-induced, but it's not diagnosed particular ILDs. But it's the value of bronchial lavage actually become much more powerful if compared with the images of high-resolution CT scan. So now, if you the NSIP pattern with the lymphocyte, it tells you that the condition is reversible. And if it's neutrophilic with the UIP pattern that is fibrotics, then means you must start antifibrotics, medication of fibrotic with activities that actually get a good outcome. However, if it's a mix, means it's a steroid response. And if lymphocytic with autoimmune like an LIP, obviously also the prognosis is quite a lot better. So now, once you've done your CT scan, obviously you have few kind of radiological evidence. One of them is really, most of the time you will encounter is a UIP pattern, which is really the horizontal CT scan finding. You see honeycombing, reticular abnormalities, traction from the ectasis, and subpleural and basal predominancy. Histological features will be a patchy subpleural or paraseptal fibrosis with temporal and partial heterogeneity and fibroblast foci. Associated CTG, of course, will be your RA-ILD, systemic sclerosis ILD, and mixed connective tissue disease. But the predominant is RA is probably most of them is about 80% of cases are RA-related, actually. The prognosis causes high risk of progression and mortality among CTG patient ILD. So if you look at the evidence, of course, 1.5 to 2 times high mortality in UIP pattern compared to with NSIP and ILD, and 46% had prevalence of UIP pattern in connective disease are RA-related, and faster decline FBC in UIP patterns compared with NSIP. This is how CT scan histology. Of course, what you see, the predominant things really is here, fibroblast foci there, and then of course, and then you look at there, and of course, and if you look at the CT scan, you see the partial predominant honeycombings, which are really predominant features. And then NSIP pattern, of course, will be those high CT finding, of course, the ground glass opacities, fine reticulation, traction from the ectasis, and subpleural sparing, and basal predominancy. Histological features will be a uniform interstitial inflammations, or what we call homogeneous, with fibrosis with temporal and spatial homogeneity. And associated connective tissue disease will be a systemic sclerosis, mixed connective tissue disease, and obviously sovereign. RA is really there in RA, but less than 10%. Prognosis better overall survival compared with UIP pattern. And the CT scan again, you look at that. The most important, the sparing of the ground glass, and obviously reticulation, and then sparing of the subpleural sparing. And when you look at the histology, normally the lung architecture is preserved. LIP patterns, image, of course, most of these patients, they got a skin wall cyst distributed diffusely as well with a ground glass opacity and smaller nodules, and diffuse lymphocytic infiltration with reactive germinal center, plasma cells, and interstitial expansion with preservation of the lung architecture. Again, it's the same as the NSIP, but it's more cystic, and associated conditions really sovereign disease, the most common, but RA. Prognosis generally favorable prognosis compared with other progressive fibrosis ILD, although risk of lymphoma quite exists. So you might need to exclude lymphoma. So evidence supports less than 5% LIP patients. LIP is very rare, seen in less than 5% connective tissue ILD disease. In South Africa, we have seen in context of HIV disease. So we normally see in that context. And then of course, 90% of the connective disease ILD with their LIP pattern are associated with Sjogren disease. Now, the last one, of course, so that this is how it really look. If you look at the cystic changes, they're randomly distributed, and they have some ground glass and the nodules. And then the last, of course, of the histological pattern, of course, will be your morphological pattern is the organizing pneumonia, and where you always see peripheral or peribronchial consolidation, ground glass opacity, reverse halo signs, which are atoll sign, and lobular patterns and migratory opacity. So the migratory opacity tend to migrate really. Histological features are intra-alveolar, parts of granulation tissue, what we call mansion bodies for the fellows, and within the lumen of alveolar and bronchioles with preserved lung architecture and chronic inflammations. Associated connective disease tend to be in RA-ILD, systemic sclerosis ILD, and Sjogren. Prognosis generally favorable with appropriate therapy. Migratory nature help distinguish from infection or malignancy. But please don't get caught out by eosinophilic pneumonias, where actually those patients also got migratory, depending on the level on the lungs. Now, this is how it looks like, and I hope you appreciate that. And then what about the role of pulmonary function? Now, pulmonary function is used for baseline assessment, is mandatory. Perform pulmonary functions such as FBC, DLCO in all newly diagnosed connective tissue disease, regardless of respiratory symptom. Because it can detect subclinical ILD and early pulmonary vascular disease, especially RA, and establish reference value for future comparisons. Screening and risk stratifications, high-risk patients those with the anti-SCL 70, anti-JO, you need to screen it every 3 to 6 months in the first year. DLC's decline may precede radiological fibrosis. ABC DLC ratio of more than 1.6, red flag for pulmonary hypertension. Now, tests to include, of course, in the baseline assessment is spirometer, where you do FBC, diffusion, DLCO, considered in the echocardiogram. The problem that people always do is spirometer, especially most of the rheumatologists, and the thing that they make the diagnosis, the issue that you need to do a full lung function test. Spirometer is not adequate enough. So the screening, of course, risk for systemic sclerosis, inflammatory myositis, and rheumatoid factor. Now, again, you can also use pulmonary function for monitoring disease progression, which later we can discuss. For example, if you have more than 10% APC decline, so this has relative decline within 24 months, regardless of symptoms, then you know that there's a problems. There's progression here. And also when there are 5 to 10% APC decline plus symptoms, or more than 15% DLCO decline. And that's what I tell you that is really trouble. The pulmonary function test again. Now, longitudinal follow-up, when you look at in stable disease, we need to do lung function between 6 to 12 months. That's your full lung function. And then, of course, in progression high-risk disease, you do lung function 3 to 6 months. And then clinical integration, what do pulmonary function tell us? FBC, of course, as I said, reflects lung volumes and restriction. Decline indicate fibrosis progressions. DLCO reflects gas exchange and vascular bed. Decline indicate parenchymal or vascular involvement, and that's required for that kind of workup. Now, 6 minutes walk test. This is one of the tests that is very underutilized. The question was 6 minutes walk test matters. It reflects excess capacity and integrated cardiopulmonary functions. Correlate with the disease severity, such as FBC, DLCO, resolution CT extents, predict hospitalization, disease progression, mortality, and easy, inexpensive, and reproducible in clinical practice. When to use 6-minute test in connective disease, in systemic sclerosis, you must be careful. Assess severity of prognosis before you recommend it, because most of these patients have a bit of muscular issues, and sometimes they cannot even do much, not because they're unable to, but because they're having the disease severity. RA, patient with limited or no lower limb joint damage. People who can walk, but anybody with joint pains, they will not be able to give you 6-minute walk test. In idiopathic myopathies, those are patients with the fractional muscle weakness that are able to walk, so means the value will be useless. Now, when you have like 30 to 50 meter low 6 minutes walk test, is associated with, of course, high risk of mortality. The hazard ratio is 1.4 to 2.5. And then when there's 25 to 45 decrease in 6 minutes walk test, of course, that also decreases over time, predict functional decline and prognosis. So the issue that the lower distance, of course, of 6 minutes walk test is increased risk of hospitalization, disease progression, and mortality. Now, screening for CT for ILD, this based on the EULA guideline in February 2026. Now, if patient present to your rooms or rheumatologist or physician with a systemic sclerosis or mixed connective disease, the same day you need to do hydrogen CT scan. However, if somebody got idiopathic inflammatory myositis with the risk factors, which I'm going to discuss later, those can be, you need to do CT scan start. And also with rheumatoid, somebody rheumatoid arthritis with the risk factors. The rest, you can defer. It's strong recommendation. Now, screenings, of course, the screening, this is really screening of ILDs. This is, as I mentioned already, systemic sclerosis and mixed connective disease. There's a strong recommendation. Routine screening for ILD is strongly recommended in patients with systemic sclerosis and mixed connective tissue disease. And if you look at this overall survival of patients with systemic sclerosis ILD, there's decreased survival of 55.6% in 8 years. So 5-year survival dropped to about 71%. This was a French cohort of 10,000 patients. And then again, the prevalence of ILD in the virus with the systemic sclerosis and mixed connective tissue disease, if you looked at the predominance of ILD in Europe, about 56% and 47%, which is quite very high. That's why screening earlier is actually make a lot of difference. Now, so now, if you look at the guidelines, of course, ILDs in those patients with the mixed connective disease and obviously and the systemic sclerosis, most of these patients normally, when they present, the user is symptomatic already. And the risk factor for ILD and of course, in the risk factor for ILD in the idiopathic inflammatory myositis, of course, will be all the age groups, 40 to 50 years, increased CRP and ERS, presence of anti-jaw, again, those markers. I hope that we will develop our own criteria in South Africa, where actually our chemists can actually provide, just inform us once they have it to say, listen, this patient is antibody, please do hydrogen CT scan. I think we need that coordinations. So those risk factors are very important. Once they have those risk factors, you need to do hydrogen CT scan. Now, what the stronger recommendation based on ERS EULA 2023 was the strong recommendation if patient have more than one risk factor only. So perform hydrogen CT of the chest immediately. Conditional recommendation is patient with no risk factors, do not routinely perform hydrogen CT scan. And again, those are the figures, 56% and 47% prevalence. What about patients with the Sjogren's? Again, those are the pool prevalence of ILD in primary Sjogren's disease is about 10%. And it's related to it, that's 10%. And then obviously, and then RA, I mean, again, in RA, the risk is really about, this is a flow diagram for RA. Again, you look at the risk factors, most important, high titer rheumatoid factors, high titer anti-CCP antibodies, cigarette smoking, older age at 50, RA onset and high disease activities. And the problem with RA, as I say, sometimes those patients are in their 70s and they immediately get diagnosed as a IPF, while they actually got RA. And the treatment is really different. And most of them, for RA, you could actually benefit from biological, while in patient with IPF, they actually do very well, or they do very bad on biological. So it means they need to be on the antibiotics. So it's very important, I think, to approach this problem properly and actually try to find underlying cause. And again, RA, as I say, is 11% prevalence. Now this comes with really one of the unresolved questions, like, about patients with RA who presented with to your practice, and out of blue, you do the first screening, CT scan, everything is negative. Should you rescan those patients? The answer is yes, because those patients, after 5 years, they actually will have features about, they'll develop ILD. And as we discussed previously on our last slides, was that most of these patients, after 5-6 years, they will actually start to develop feature ILD despite normal lung function. So you might have to consider looking at the risk factors and modify your screening criteria. That's why it's very important for rheumatologists that they should be aware of the ongoing risk of ILD in patients with RA. So risk screening should be considered in patients with a risk factor for ILD, even if the initial screening was normal. Now, multidisciplinary meetings, which is in South Africa, we don't do much of those, but I think probably we need to start forming those MDM meetings. And this really, most of the time in South Africa, respiratory physiology and pulmonologist is one thing that's really shared, but radiology is very important. Clinical nursing specialized, obviously, which we don't have that, but I think we need to train those. And of course, physiotherapists or those involved from rehabilitation, they're also, I think, the key pathologists and rheumatologists. But pathologist part does not really play a key part in it anymore, because the reason that, unless if they really have to discuss about the serological markers, but biopsy has become more really, we don't use biopsy that much. And most of the time, after multidisciplinary discussion, then we consider whether we need to do a biopsy or not. Now, post multidisciplinary discussion, biopsy rules comes into play. So the current international guidelines recommend that the lung biopsy should only be considered after multidisciplinary discussion has failed to reach a high confidence diagnosis based on clinical, serological, and high-resolution CT data. So the major contraindication, of course, would be anybody with severe pulmonary hypertension with mean pulmonary arterial pressure more than 25 is a no-go area. Evidence is because it's increased the pre-procedural mortality and complication in patients with the pulmonary hypertension, and also retrospective cohort studies show up to 10 to 15% 30-day mortality when mean pulmonary arterial pressure is more than 35%. So please, no biopsy for anybody with the biopsy. Before you actually send some biopsy, please get cardiac echo baseline. And if that's positive, consider right heart cath. That, of course, which is 30-day mortality, about 10 to 15%. Major risk factors, of course, acute exacerbation during procedures. Most of the patients that went for biopsy will develop acute exacerbations. Evidence against, within hospital mortality, 20 to 40%. So, but who is indicated for biopsy, of course, will be those with uncertain diagnosis despite multidisciplinary discussion, those with overlap or atypical imaging patterns, and those with potential treatable alternative diagnosis, suspected easy infection, vasculitis, or malignancy, or sarcoids, or consider when results will change management. That's when we really do our biopsy. So now, biopsy strategy in ILD yield with some risk. Of course, transbronchial biopsy really got low yield, best for infection or sarcoid evaluation at low risk complications. While cryo biopsy, good architectures yield about 75 to 80% ILD diagnosis when adequate tissue and architecture are needed with low risk, moderate risk, and the risk is really bleeding, while surgical lung biopsy is gold standard. But most centers are leaning towards cryo biopsy as the first line. Now, why timelines matters? The problem that the timing of ILD relative to chronic tissue disease diagnosis what has prognostic and management implications. So there are three really domains criteria identifying patient with interstitial pneumonia who has features such as autoimmune diagnosis, but do not really meet criteria for defining connective tissue disease. But the problem with the patients with the connective tissue disease, when they present, they can present either first get diagnosed with the connective tissue disease, and then after that proceed by interstitial lung disease. Or they can actually present with interstitial lung disease and later get diagnosed by connective tissue disease. Or they can also have the vice versa, where they actually have connective tissue disease and ILD only a few years later. Or sometimes they can have ILD with either that can differentiate full connective tissue disease or never at all. And that's why it's very interesting, you always keep you going. And this is really, again, when the cohort that was done in France, and they look at about the diagnosis of the ILD, especially in patients with the IPAP, where most of the 20% of the CT-ILD at ILD onset and more than 6 months before connective tissue disease was diagnosed. Now, if you look at this diagram, it really tells you about when the onset and how many of them actually presents from the RA, SLE, systemic sclerosis. And what was more important to come out of these studies that SLE does not really give you ILDs, but what it can do can give you other issues like sinusitis, can give myocardial or pulmonary hemorrhage, but never really give you one of the patterns, morphological patterns. So in the past, we always have to look at it. When you look at the UIP pattern, we think it's SLE, but no, SLE does not cause UIP pattern, does not cause organized pneumonia, does not cause bronchocentric interstitial pneumonitis. So it's really more involved other organs. And autoimmune. Now, let's chat about these autoimmune features, which is probably one of the very important in pulmonology that we see quite a lot. So this is a three-domain criteria identify patients with interstitial pneumonia who have features suggest of an autoimmune features, but do not meet criteria for defining connective tissue disease. So to be diagnosed with IPAP, a patient must have interstitial pneumonia by hydrogen CT scan or biopsy, number one. Two, at least one of the features from at least two of the three domains. Those three features are clinical domains, where they have mechanical hands, featuring cracking of the fingers, goated fingers, random phenomena, or inflammatory arthritis. Surgical domains, of course, the ANA, which they got higher titers of 1 to 3 ANA, which have to be either nuclear or sparkle. And specific autoantibodies, which titer doesn't matter, anti-CCP, RF, anti-RO, anti-LA, or mastitic specific antibodies. Morphological domains, those will be an NSIP pattern in the CT scan, and then ground glass opacities, or organized pneumonia, or multi-compartment involvement. Now, so there's quite a very good prognosis, because in the past, we just told them that, no, this is IPAP. It's very important to indicate whether it's a IPAP, UIP subtype, or IPAP, NSIP subtype. The reasons why now, if it's a IPAP, UIP subtype, most of these patients has poor prognosis, so they need to be started antifibrotic immediately. However, if the IPAP, NSIP subtype, they got more better prognosis. And if you look at the median survival of the UIP, IPAP, it's about 3 to 5 years. While with NSIPs, more than 5 years survival rates about 7 to 85%. So it's always very important to really, really distinguish this patient and start on the appropriate therapy. And then progressive pulmonary fibrosis, of course, progressive pulmonary fibrosis is in non-IPF interstitial lung disease with radiological, physiological, or symptoms, evidence of progression leading to a poor prognosis. I always say that rheumatologists for a long time, they've been relaxing quite for a long time. Out of blue, they're having emergencies, some that they can run to. They just kind of show up to work at 7 o'clock, at 9 o'clock, because they will have patients that come with it who are stable now, having acute shortness of breath. Now they need to rush to consulting room, emergency center to make sure that those patients has no progression. So the progressive pulmonary fibrosis affect, of course, heterogeneous population ILDs. And if you look at the diagram here, IPF is one that the first study was done in IPF, but now in the connective tissue ILD is about 1.8 to 24.8%. So early identification of progression is critical for timely intervention. That's why, again, we mentioned that patient with the mixed connective disease, scleroderma, those patients might need lung function 3 to 6 months, so they can pick up those patients much more earlier. Now let's look at the diagnostic criteria for progressive pulmonary fibrosis. The ERS ATS guideline, diagnosis of PPF, require more than 2 of the following criteria within 1 year, with no alternative explanation for progression. And those patients might need alveolar lavage. Worsening respiratory symptoms, such as worsening of dyspnea, cough, or other respiratory symptoms, and then physiological progression, absolute decline FVC of more than 5% predicted, or absolute decline in DLCO uncorrected of more than 10% predicted. And then physiological progression, increased external fibrosis and high-resolution CT scan consistent with progression. So PPF is identified patients at high risk of adverse outcome who may benefit from antifibrotic or immunomodulatory therapy and closer monitoring. Now, based on my experience, I thought I should come my own approach to ILD chronic tissue disease. So obviously, the most important thing is not very difficult for fellows. It's very easy. We just look at the ILDs in chronic tissue disease. In the past, we like very scary, but actually not scary. You basically divide it into the 4 patterns. 1, fibrotic process, which is UIP-like patterns. 2nd, inflammatory process, as NSIP-like pattern, and alveolar filling process, and cystic lung disease. That's how you approach them. There's really 4 domains. Now, for fibrotic process or UIP-like patterns, of course, as I said, subpleural, basal predominance, reticulation, honeycombing, retraction bronchiectasis. And the most commonest associated with the rheumatoid arthritis in 90% of UIP are mostly RA. Treatment first line is MMF based on EULA guideline. But in our practice, if they got severe disease, we go for rituximab first line in severe case and maintenance of MMF. While inflammatory process, NSP-like patterns, again, we should bilateral symmetrical ground glass opacity, fan reticulation, subpleural sparing. The common connective tissue association are mixed connective tissue disease, idiopathic inflammatory myositis, and Sjogren. Treatment first line is MMF, but if they got acute respiratory failure, most of the time, and if they are less than 40 years old, you have to really think carefully. You have to use either tocilizumab as a induction. In my practice, I will use cyclophosphamide, provided that they are not in there. They are not designed to have children, because the issue you always cyclophosphamide in female, you must get a consent. If they finish their family, become the first line. If they haven't finished their family, you have to discuss with them and make sure they must sign consent, because otherwise you treat them, they recover fully, that they want to have kids. Now their ovaries are not working, then you're in trouble. So you have to get it really quite good consent. Rituximab, always we can use that as for maintenance later. But I think it's a first line, sometimes the onset is too slow. So you have to use quite more, I think tocilizumab will be the first line treatment. Steroids is reserved for those who are not in respiratory failure. So in my practice, I think endoxifen will be the first line. And then or if they're in birth, where they're in childbearing age, then I go for tocilizumab plus steroid and then maintain MMF. Alveolar filling process, steroids is the kinks. They don't respond very well, but to be careful, some of them are steroid dependent. So you stop the steroid and other they progress. So you might need to use the immunosuppression for maintenance. Cystic lung disease, such as LIP patterns, of course, which is also again most common CD associated with the Sjogren. Again, the first line is steroids, and then you rituximab become if they're refractory to the treatment. Now, and this is really basically what I did. I think for fibrotic process, this is what happens again, and then also for the inflammatory process, NSIP, this is really what you do, and then again for the alveolar process, again, which I mentioned, patient peribronchial treatment, also high dose steroid, 0.5 milligram to 1 milligram per kg. And then, slides. Okay. This fancy slide, sorry, 1 minute. Yeah, okay. So I just want to touch quickly about immunosuppressive connective disease. All of us are very quick to prescribe them, but I think it's better that we need to understand what the immunosuppressive really all about. Immunosuppressive got benefits and also got risks. Okay, so the benefit, of course, potential for improvement, rapid with the steroid, slower with other immunosuppression, with improvement in breathlessness. Improvement also greatest when morphology suggests significant inflammatory process. That's important. Your diagnosis have to be right. You just cannot just start treatment. You need to really understand that you relate to the inflammatory process, and should prevent or reduce likelihood of development of fibrosis if treated earlier, and can benefit extrapulmonary connective disease. Okay, the risk, unfortunately, that severe potential life-threatening infections such as PJP, CMV, and tuberculosis in our context, and recurrent chest infection may themselves contribute to progression of fibrosis or trigger acute exacerbation of ILD and multiple comorbidity with long-term use of corticosteroid. That's why these patients you always must exclude. I think SARA guidelines is clear, they exclude TB. They're really quite more meticulous exclude TB. They're better than even pulmonologists looking for TBs and PJP and of course the others. And then antifibrotics therapy in connective tissue disease, benefit and risk. Of course, the benefits that one of the things really about antifibrotics that they slow the progression of fibrosis in connective tissue disease ILD, but they don't prevent it, they don't reverse it. So overall safety is acceptable, but tolerability challenge and lack of symptom or extrapulmonary benefit limit overall. So now, benefits overall in clinical trials, antifibrotics, nintedanib and pirfenidone demonstrate acceptable safety profiles. Most adverse events are manageable. Evidence which you've seen in field trials and census trial. The reduced rate of progression fibrosis, both nintedanib and pirfenidone, of course, significantly slow the annual rate of decline in FBC compared with placebo and connective tissue disease. But the problem with the antifibrotics, they really does not improve your shortness of breath. Patient will still have ongoing shortness of breath. Okay, that's really the problem. And then of course, the risk, high rate of discontinuations, which really well studies report high discontinuation rate with nintedanib and pirfenidone, up to 30 to 40% due to gastrointestinal side effects. Can increase fertility. Gastrointestinal side effect, it means diarrhea, nausea, and anorexia may lead to weight loss, reduced muscle mass, potential increased fertility, especially older or vulnerability. But what I emphasize is that they do not improve breathlessness or extrapulmonary disease. Antifibrotics do not significantly improve disease score or quality of life. But in South Africa, it's also extremely very expensive. So, and this is really my approach pneumonia for connective disease called STAR-T. Connective tissue ILD is a treatable disease if you treat the right phenotype at the right time. So now STAR-T stands for S, start earlier. Identified ILD using hydrogen CT scan, physiological before symptoms progress, intervention to preserve lung function, improve survival. T stands for target inflammatory first, use mycophenolate as the backbone for therapy for inflammatory phenotype, supported by SLS3 study. A stands for antifibrotic therapy if the disease is not improving, and there's evidence for that. R for recognizing the pivotal to fibrosis progression displayed immunosuppressive signal and fibrotic phenotype to not excrete immunosuppressive blindly. And then R, T standard art biological. Tocilizumab and rituximab have role in specific inflammatory or refractory subsets. E, escalate appropriately. For refractory or rapid progressive disease, consider combination therapy, immunoglobulins or transplant referral earlier. Delay wasn't outcome. And A is think multidisciplinary, act decisively. Optimal outcome depends on horizon CT scan, pulmonary function test, and ethical and clinical phenotypes, multidisciplinary discussion, decision making. So the real treatment for the right phenotypes at the first time can change the course of CTD-ILD. Thank you.
Yes. quite a lot of people online, and some of them are the fellows in pulmonology. I'm not sure if we can open the floor and see if there's anybody online who would like to ask a question.
Fellows, anybody?
See there.
Any questions?
No, no question from my side. Good morning. Very great presentation. Thank you for a good overview. Thanks a lot.
And our pulmonologist online, Farai, any? Oh, Beef, do you have a question?
Hi, Dr. Taban, how are you?
I was talking to you. I think our last time we spoke to you was when you're doing internal medicine. Congratulations! I heard the pulmonologist.
I just want to say thank you for a wonderful talk. I think it was very useful. And then maybe just to let everyone know that in terms of the cryo lung biopsy, we are actually doing it at Mucus. And then, we're also hopefully looking to expand it a bit into the private sector around there. But yeah, we have done about 15 cases so far with good yield and some interesting, diagnoses. We have a few patients with sarcoid and follicular bronchiolitis. So it is something that is available. We fortunately haven't had too many complications thus far. I think one pneumothorax to date, no major bleed. So something that we are hoping to grow. And just if anyone, does have any cases or any interest, we are doing it at Charlotte.
No, thank you for the information. Yeah, I think it would be nice actually if you also expand to the private sector, because that's where I think probably needed, because in the government sector sometimes you don't really have much of those patients, but in private they really love pathological patients that might need biopsy. Biopsy must be that's one of those good days.
Yes.
Pulmonologist, how's a cryobiopsy day?
If do you want to explain that further?
Yeah, I can. So what we do, so it's done currently we do it with general anesthetic, just for obviously the patients to be safe. And then we do a normal bronchoscopy, go through to the specific area or lobe that's affected, obviously reviewing the CT scan, see where we're going to get our highest yield. Then there's a special cryo probe that's then passed through the working channel of the bronchoscopy, kind of similar to how we do a transbronchial biopsy. Pass the probe through, also under fluoroscopy guidance. We have the C-arm to make sure that we're in a good region. We also don't want to be too central because, as Dr. Taban said, those with pulmonary hypertension have a higher risk of bleeding. So if you're too central, you're more likely to the bigger blood vessels. So increase your bleeding risk. You also don't want to be too peripheral because you increase your risk of a pneumothorax. Obviously, you get some pleura. So we make sure we're in the diseased area, but not too central or not too distal. Then the cryoprobe allows us to freeze. So we freeze normally for about 5 to 7 seconds and then extract the sample tissue on block. So we pull out the entire scope with the cryoprobe still attached, and then we put it in the saline just to warm it up a bit and then transfer it to the formalin. And we're getting, like I said, good size pieces, normally about a 0.5 to 1 centimeter diameter, which compared to the even forceps or transbronchial biopsy, those who have done those know that it's quite a significant increase in the size of the specimen.
Do you guys got the balloons? Because
I also meant to mention, I realized I forgot to mention that. So we do use a balloon to prevent bleeding. So the balloon is passed through into the segment that we're going to biopsy, into one of the segmental bronchi or subsegmental bronchus. And then as the cryoprobe is pulled out, the balloon is inflated so that any bleeding is contained distal to where basically the balloon is inflated. We then go back once the sample has been put in the formalin. We then go back with the scope, check the balloon. Fortunately, if it inflates well, you can put the bronchoscopy scope on top of the balloon. You can actually see distal to see any bleeding. If there is, then we just keep the balloon inflated a bit. The balloon has a port where you can install adrenaline, cyclocapron, even cold saline distal to the balloon to help with the bleeding. And if we don't see any bleeding, then we slowly deflate the balloon again, watching for any undervision, watching for any blood that may come past. And if it's clean or nothing, then we deflate the balloon completely and then take a second or third sample, depending on how many we're looking to get.
Yeah. We have a second pulmonologist on Ryan to cry. You have done quite a few cryo biopsy. Is that all that you're going to be doing them soon in private?
Morning. Hi, Emmanuel. How are you? Thanks so much. It was great talk. I really enjoyed it. I think with the cryos, yes, I've done quite a few, but that was at Kurdistan in private. So it's going to be a challenge to get there. I mean, the machines are also quite difficult. Just doing e-buses in private is also still a big step. In terms of connective tissue ILDs, I mean, a lot of these cases are quite tricky, and these forums are quite a great privilege to have to discuss these cases because they're not easy. And doing a biopsy, some of these patients will decline biopsy. So it becomes a little bit difficult to make decisions. And now you base it on just radiology. So this is quite a good forum to probably have these discussions.
Yeah. I think perhaps in 2-3 years' time, we will be having a lot of the, what you call the AI radiology, which would be quite very useful for us to be able to radiology, because the problem that most of radiology practice across South Africa, they're very busy practice. So there's nobody really that dedicated doing the lung CTs and that if you don't have that support, you can't really struggle. And if you can't make right diagnosis, you will struggle to actually to initiate antifibrotics, and medical aids are not even that kind either. So you have to get your story right, yeah. But I think we should be working together because there's just so much to go around to make sure that we could kind of to benefit our patients, yeah.
So my last question would probably be, how has it been trying to get antifibrotics for your patients? Because obviously just getting cyclophosphamide or MMF is already a challenge. So how are you guys finding it to get antifibrotics in the private sector?
I think I'm quite very lucky in private sector because I have myself, we're 2 pulmonologists, and then we're having 2 rheumatologists. So most of the time we don't have issues getting our treatment for chronic tissue disease because we work a lot with discovery, GEMS and all them. And I think once and most of the time we have, I think 95% we always get in the cases, but now I think discovery has gotten much more difficult now. Based on the plan, they can't say if you're on the primary saving plan, you cannot access it, which I think for me is quite rather very sad because somebody has paid for medical aid. They never knew that they're going to get sick, but now after they get sick, then say, no, we can't pay that. And I always say, argue with them that the patient already have, they will get diagnosed newly, just treat them for 1 year and then ask them to upgrade medical aid. So, but we really drive a lot of motivations, and I think most of our patients are getting proper treatment. However, I think that the Tenet and the Pephenidone in private practice is about 8,000-9,000 rand. And I think if you have connective tissue disease, you need to consider about actually that most of the immunosuppression, they also got antifibrotic activities like rituximab, Salsep. So you could actually combine them. So most of the time I end combining dual therapy or triple therapy, depends on the condition. So I think our next discussion will be about the treatment of ILDs, which probably be the next discussion, and discussing about which actually suppressant got antifibrotics and which one does not have, and when to actually use combination therapy. And that'll be the next discussion.
Perfect. Thanks so much. I really appreciate it.
Thank you. Any other questions? If not, I want to say thank you guys for joining us, and all the presenter will be available on podcast in our YouTube channels, which if you go Google, you'll be able to share the information, and then also all this is also CPD accredited. Please submit your names, then you can get your CPD points, which will register automatically. And please join us every Wednesday. We have this discussion every Wednesday. Thank you so much. And you're welcome also to present, share your knowledge with us. Biff, I'll be sending you a date so that we need you to present to us, share your knowledge about the public sector.
Thank you so much. Have a good rest of your week.
Thank you.